This next paper is on long COVID, musculoskeletal conditions, and resultant pain. It looks at research between December 2019 and August 2022. Now, pain is a predominant symptom in long COVID patients, with nearly half of them reporting pain, both new pain or an exacerbation of chronic pain, where the most prevalent symptoms were headaches, chest pain, back and neck pain, muscle pain, and joint pain. Where in one very large COVID-19 study had 43% of patients reporting pain in their medical records 2 to 4 months after illness, with this being acute illness, so just the COVID infection, not the long COVID necessarily itself, with joint pain and headache being the most frequently reported condition. For hospitalized patients with COVID, in that study, they found that 73% of these patients had neurologic symptoms, including headache, the muscle pain, and then impaired consciousness. Regarding arthralgias, two pain categories exist: bone and joint pain, with neck, back, and lower back pain being predominantly reported symptoms. And these symptoms actually seem to increase over the first year for the long COVID patients, which means that the pain is getting worse over time. In a single cohort study of hospitalized patients that did not need ICU treatment, 40% had widespread pain and 23% had localized pain, and the lower legs being the most common, where the muscle and back pain is typically resulting from paraspinal myositis, which can be shown on MRI findings showing intramuscular edema. So this is the sort of fluid buildup around the bilateral erector spinae and multifidus paraspinal muscles. So this is in the lumbar spine region. And this is important to diagnose because early on treatment can help. There's actually things that can treat this. So COVID-induced pain is typically believed to be due to the cytokine storm, these inflammation mediators within your bloodstream that can be directly damaging nerves through the microglia, resulting in focused joint pain in the knees, the hips where the femoral head is, the elbows, and the shoulders. Additionally, it's believed that the fibrin amyloid microclots, these fibrous microclots, are causing some of the pain issues. In the blood, you can measure these through D-dimers, von Willebrand factor, and fibrinogen levels. And the really scary thing is that your body is not able to easily break down these fibrous microclots once they develop. They're very resistant to fibrinolysis, which is the body's natural defense at breaking down these fibrous microclots, typically, where they can pass through the microcapillaries and cause blockages, and it's believed that these blockages are sort of the source of the pain. And because they're fibrous, they're sort of mobile in a way, so they can actually migrate. So it's believed that the fibrin microclots may be one cause of some of the transient or migratory pain that occurs, along with neurologic symptoms that many long COVID patients experience. For long COVID laboratory testing, they recommend doing a complete blood count with differentials, C-reactive protein or erythrocyte sedimentation rate, complete metabolic panel, magnesium level, thyroid function test, ferritin, iron panel, vitamin D level, hemoglobin A1C, and when pain is present, consider uric acid, rheumatoid factor, anticyclic citrullinated peptide, CCP antibodies, and or antinuclear antibodies, ANA. Reflexive panel with titers, among other autoantibodies depending on the patient's personal and familial history. So the ultimate takeaways from this article are that painful musculoskeletal conditions are common in long COVID patients, where there are multiple co-occurring pain symptoms, and that treatment strategies should be holistic, taking into consideration other long COVID symptoms and a biopsychosocial treatment approach.